receiving bedaquiline in a compassionate use program in Armenia and Georgia. That we have Dr. Helswin.
Could we have the pointer, please? Coming.
Okay, hello. Okay, good afternoon. I'm going to present some results on culture conversion and reversion of multi-drug resistant tuberculosis patients receiving bedaquiline through a compassionate use program in Armenia and Georgia. So bedaquiline and delamanid have both recently improved perspectives for patients treated for multi-drug resistant tuberculosis. In clinical trials, they showed faster time to culture conversion, better culture conversion, and improved outcomes. Back in 2013, WHO issued interim policy guidance on the use of bedaquiline. And at this time, they recommended a maximum of 6 months duration for bedaquiline. This was largely related to the anticipated effects, undesirable anticipated effects, which were considered as large at that time, which was mainly due to the high mortality seen in the clinical trial in the bedaquiline arm compared to the control arm. Since 2013, in 2017, WHO issued a report on the Guideline Development Group meeting on the use of bedaquiline for MDR-TB patients. This was a multi-centric cohort of 537 patients from 5 countries, and it showed good culture conversion of 80%, good outcomes of 70%, and particularly the safety concerns were downgraded from large to moderate. This was because of reduced mortality seen in bedaquiline-treated patients as compared to others. Another publication of Gigliometti, this cohort is included in the multi-centric analysis. The majority of patients received more than 6 months of bedaquiline. 15 of those patients received bedaquiline for the full treatment. They had excellent outcomes, and there was no difference between the two groups, people who received less than 6 months or 6 months of bedaquiline to those who received more. And it's particularly important, there was no difference in tolerability between the standard and prolonged bedaquiline. So before bedaquiline was widely available through global drug facility or through the pharmaceutical company, compassionate use or expanded use mechanisms were used by countries to get access to bedaquiline. These compassionate use mechanisms are a little bit complicated. They require case-by-case approval by the pharmaceutical company. They have quite strict inclusion criteria. It was only for pulmonary MDR patients. And particularly, there was a limit of 24 weeks of bedaquiline, and there was no possibility to extend beyond 24 weeks. The drugs were provided free of charge by the drug company on a patient name basis only. But these compassionate use mechanisms were extremely useful to allow early access to patients who really had very, very limited treatment options, as you will see. So the objective of this presentation is to show the rates and time to culture conversion and reversion amongst patients receiving 24 weeks of bedaquiline through compassionate use in individually constructed and adapted treatment regimens. So this cohort of patients come from 2 countries, Armenia and Georgia, 2 countries in the Caucasus region of Eastern Europe. Both countries didn't have compassionate use mechanisms before this time, and they developed these mechanisms for the use of bedaquiline, and it has served them for both bedaquiline and delamanid. MSF has been supporting the National Tuberculosis Control Center in Armenia since 2005, and the first bedaquiline patient started under compassionate use in April 2013. In Georgia, MSF has supported the National Tuberculosis and Lung Disease Hospital since July 2014, and the first MSF-supported bedaquiline patient was in July 2014. However, in Georgia, compassionate use had been used prior to the support from MSF. When MSF worked on the bedaquiline compassionate use, we also introduced linezolid and imipenem at the same time in parallel. So patients were having access to 3 new drugs in these 2 countries. Monitoring and reporting of safety were as per the compassionate use protocol. So this is a retrospective analysis. All patients receiving bedaquiline under compassionate use in Armenia and Georgia between April 2013 and April 2015. We define conversion as 2 consecutive negative culture results at least 28 days apart in culture-positive patients at treatment start. And reversion was 2 consecutive positive cultures, 28 days apart, amongst patients who had already culture converted. So I'd like to say about these patients were very sick patients. Some patients were even on palliative care. As you can see here, the majority were men with a median age of 40, but they had extensive disease. 86 had cavities on chest X-ray. All of them had been previously treated with second-line drugs for TB. A large percentage, 43%, were hepatitis C positive, and the majority were fluoroquinolone resistance, with almost half being XDR. When bedaquiline was used under compassionate use, 100% of patients also received linezolid, 82.9% received clofazimine, and 75% imipenem. So here are the results of culture conversion. Of these 82 compassionate use patients who received bedaquiline under compassionate use, 64 were culture positive at the start of treatment. Of these 64, 54 or 84.4% culture converted during the treatment, at any time during treatment. Here we can see the Kaplan-Meier curve of the time to culture conversion. So at 2 months, 31% of patients had culture converted, and at 6 months, 74%. The median time from treatment initiation to conversion was 2.7 months. Now culture reversion. So out of those 54 patients who had culture converted, 10 or 18.9 reverted back to positive. The median time to reversion from the treatment start was 7.9 months. So 80% of the reversions occurred after 6 months of treatment. So we think that this shows very high rates of culture conversion in these highly resistant, previously treated, very sick MDR-TB patients who all received bedaquiline under compassionate use conditions. We see a high proportion, 19% of reversion, mostly occurring after 6 months of treatment. And this for us is very, very alarming. Compassionate use has been extremely useful in these settings. These patients got access to bedaquiline 2 years before other patients in the world got access to bedaquiline through Global Drug Facility. However, compassionate use mechanism does have some limitations, and in this case, we think that it was restrictive on the bedaquiline duration. These patients need enough effective drugs, and as you could see, most of them had had all second-line drugs previously. So introducing imipenem, linezolid, and bedaquiline gave them at least 3 effective drugs. But stopping an effective drug when you've only got 3 effective drugs at 6 months was very against the heartfelt needs and wants of the doctors. But it was a restriction under compassionate use. But compassionate use is very useful, and it's important to have this mechanism in your country because there are other new drugs coming. And it's always great to have access to these drugs for the difficult patients 2 years before you can get them through the usual mechanisms. But WHO has recently issued a best practice for off-label use of new drugs. More than 6 months of bedaquiline is not actually off-label. In the European Medical Agency registration for bedaquiline, they do say for selected patients with limited treatment options that a longer duration can be considered. And we would say to have enough effective drugs after 6 months in these sorts of patients with high risk of poor outcomes, bedaquiline should be continued after 24 weeks. So thank you to the patients and everyone involved in this analysis.
Thank you, Dr. Catherine. We have time to take 1 or 2 questions. Okay, we're seeing 1 and 2 hands, okay? You need to go there. Thank you.
Is it working?
Is it working? Yes, it's working.
Hello. Thank you for your presentation. I'm from China. I'm Frank Wang. And I have a question about the enrollment criteria for the bedaquiline patients. Out of the 82 patients using bedaquiline, only 64 is culture positive at the beginning. But according to this label of bedaquiline should be used as drug sensitive, confirmed drug sensitive patients. That means it requires a culture positive result. So I just want to ask why do you enroll this culture negative patient? On what basis do you enroll the culture negative patients? Thank you.
Thank you, very good question. 100% of these patients were confirmed drug-resistant TB patients, and we had very strict criteria of what we considered the baseline culture. So you had to be culture positive within 3 months before starting the treatment. So some patients had a positive culture. The palliative care patients, for example, we weren't doing any more cultures on them. We knew they had TB. So we said that we didn't have a positive culture for them. So we're very strict on the criteria of a culture. But all of these patients are confirmed drug-resistant TB patients, and they would not have been accepted for compassionate use if they were not. They required a DST for every patient.
So I understand that all of the patients is culture positive at the beginning, but maybe some of them already received some kind of treatment, and then bedaquiline is added in the middle or during the treatment. So that time is culture negative.
No, all of these patients started a regimen with bedaquiline and Lizolid and the other drugs. They started from the beginning with bedaquiline. But some of them, they had confirmed drug resistance, but it was from a culture before 3 months of starting the treatment. So we knew they had confirmed drug resistant, but they didn't have a culture close enough to start date that we could say for sure they were culture positive at start date. And that's why they're not included in the culture conversion.
Okay, thank you very much.
Okay.
Thank you. Due to the limit of time, can you keep your question till the end of the session? If we still have time, we can discuss so that we can move forward to the next presentation. Thank you, Dr. Catherine.
Our next speaker is Dr. Alena Skrahini from Belarus, who's going to give us the experience from working with bedaquiline in Belarus. Doctor, you have the floor.
First of all, let me express my sincere gratitude to organizers. For the invitation me and opportunity to make this presentation. A gradual decrease in TB incidence has been observed for the last decade in Belarus, with incidence 28 per 100,000 population in 2016. Nevertheless, as estimated by WHO in recent global TB report, Belarus is among of the countries with the highest MDR-TB proportion as in Europe as well as in the world. For many years, MDR-TB proportion gradually increased and reached very high level. In 2016, 68% among previously treated and 36% among new cases. In 2016, majority of cases were with advanced drug resistance profile, about 2/3 with pre- and ex-DRTB. Treatment outcomes are also poor. Treatment success in MDR-TB in 54%, treatment failure 23, loss to follow-up 12, and 11% of patient dies. The treatment outcomes of ex-DRTB are much more disappointing. Treatment success only 36%, treatment failure 40, and 17% of patients dies. So new effective MXDR-TB treatment options are vitally important for the country. Rapid uptake of new drugs and regimen is one of key direction of National Strategic Plan. Here's a list of TB drugs which have recently been introduced in the country to treat MXDR-TB. New bedaquiline and delamanid started from 2015 and June 2016, respectively. Repurposed drugs, linezolid, clofazimine, carbapenems, were introduced earlier. The country follows all 5 conditions for new drugs listed in key WHO documents: careful selection of patients, close clinical monitoring, a regimen designed based on WHO principles, patients' informed consent, and active monitoring and management of adverse events. MDR-TB Consilium is a board of experts. Each MDR-TB case considered for new drug treatment containing regimen is discussed here, covering the following issue: careful patient selection, design and treatment regimen, adherence issues, management of comorbidities, drug adverse reaction, alcohol and drug abuse, mental health problem, indication for surgery, social support. According to recent WHO recommendations, there are several steps to build effective MDR-TB regimen. If possible, start with pyrazinamide, then add 1 quinolone, then 1 second-line injectable, then 2 or more drugs from group C, then 1 of group D2, then drugs from D3, and then D1 drugs. In Belarus, according a recent study published in Lancet, pyrazinamide resistance has 81% of all rifampicin-resistant cases. This proportion may be much higher in pre- and XDR TB. In Belarus, in 2016, about 3/4 of MDR-TB were pre- and XDR TB cases. So there is limited choice to add quinolones and second-line injectables. Moreover, according to LPI testing in Belarus in 2016, 97% of isoniazid resistance was due to mutation in CAT-G, and only 3% due to mutation in ANHA. High-dose isoniazid in these cases can be not effective. So new and repurposed drugs in Belarus often can be only one of the first choice in regimen building. Regimen design was based on careful assessment of drug resistance, susceptibility profiles of Mycobacteria tuberculosis strains, history, including drug tolerability, comorbidity, severity in disease. The backbone of the regimen is combination of bedaquiline or delamanid, linezolid, clofazimine in intensive phase, and linezolid, clofazimine in continuation phase. Active drug safety monitoring and management. There is a table of patient visits with basic procedures and investigation to be done and each visit. An example of monitoring one of the most important parameters, adverse event of special interest, corrected QT interval. In most cases, QT interval prolonged in 1 month of treatment and return to normal in 2 months without any intervention. Actually, by now, we have got 480 patients on new drug-containing regimen. But we did analysis for 422 patients, including 23 children in Belarus who are on new drugs. 361 on bedaquiline, 56 on delamanid, 5 on both. 208 patients on bedaquiline-containing regimen are treated for more than 6 months, 168 more than 1 year. So it is already possible to do interim analysis. 4 patients is already cured, 1 failed, 8 patients lost to follow-up, and 3 died. Of those who were lost to follow-up, majority were alcoholics. 1 was with multiple organ abnormalities. 1 was a former prisoner and was imprisoned during a treatment, and 1 disappeared abroad where he had a job. 7 from 8 were found and transferred to compulsory palliative or conventional treatment. So in our study, alcohol abuse, history of imprisonment, job abroad were related to loss to follow-up. There were 3 deaths. 1 was due to HIV/XDR, TB further progression to dissemination disease and CNS involvement. 2nd was acute heart failure on ground and alcohol abuse. Causal relationship with treatment is possible. And 3rd was unexpected sudden death, and patient finished bedaquiline 3 months ago. Postmortem examination revealed mesenteric thrombosis and pulmonary embolism. 75% has culture conversion after 3 months of treatment and 98% after 6 months. 100% of patients had smear conversion at 4 months of treatment. All 100% of patients develop adverse event with serious adverse event developed in 5% of patients. Fatal outcomes already described. The following adverse events were registered: allergy, anaphylactic shock to imipenem, cardiovascular disorders, plasma electrolyte disturbance, hepatobiliary. Oh, I didn't see. Hepatobiliary disorders, such as toxic hepatitis, renal and urinary tracts disorders in form of hepatotoxicity. Most adverse events were mild and moderate. Rating on frequency, metabolic disturbances 74%. Excuse me, I didn't see very well.
Could you please conclude?
Yeah, and so I will conclude it. And all these which were severe on the previous slide, we have in moderate and form also. So, in conclusion, our interim results show high culture conversion rate and safety on new drug-containing regimens. Our patient series will help to increase the global knowledge of M-XDR TB patient treated with new drugs. So my granddaughter always inspires me in my work. Thank you for your attention.
Thank you very much. We have time for 1 question. We're running a bit over. If you have any question, please go to the mic. But we're running a bit low behind, so I don't see any hand. Thank you very much, then.
Speaker is Dr. Matthew Basta. He will present bedaquiline and the linezolid-based regimen for quinolone-resistant MDR-TB. How much better is this one or next one?
Actually, I switched my two presentations, so I will present first the following of the presentation from Cathy, which is the outcomes of the MDR-TB patients receiving bedaquiline in the compassionate use program in Armenia and in Georgia. And this work was done jointly with MSF and Epicentre and the team in Georgia and Armenia. Okay. Cool. Can we go back? Oh, cool. Okay, so as you all know, the treatment of MDR-TB patient is very difficult, is long, and a toxic combination of TB drugs, and only 50% of treatment success according to the WHO Global Report. Bedaquiline, initially available only through compassionate use, has greatly improved treatment prospects for MDR-TB patients, particularly the most resistant patients. So the objective of this presentation was to assess the treatment outcomes of the first patients receiving bedaquiline in Armenia and in Georgia in the compassionate use program. So the context Cathy explained already, but I will just refresh your... so in Armenia, this is a country of high rates of MDR-TB. The success rate in 2013 was 43% among MDR and only 20% among XDR. And we got also patients with no treatment option that are actually on palliative care. In Georgia, also a country of high rates of MDR-TB, the success rate in 2013 was quite similar to in Armenia, 43% among MDR and only 21% among XDR. And we observed an increasing number of pre-XDR and XDR patients in this country. The compassionate use program, so very briefly, bedaquiline in compassionate use was available in Armenia since April 2013 and since July 2014 in Georgia through individual patient application, and the supply of bedaquiline was limited to 24 weeks. So this is a retrospective analysis of the routinely collected data. The bedaquiline compassionate use cohort is made of patients started on bedaquiline between April 2013 and April 2015. All patients received an adapted treatment regimens of effective drugs based on resistant profiles and previous treatment exposure. Linezolid and imipenem were also available to construct the initial regimens. And in this presentation, I will describe the treatment outcomes and the risk factors associated with unsuccessful outcomes. So the baseline characteristics of the cohort is quite similar to the one that Cathy presented, but I will just go briefly. So as Cathy said, it's really a cohort of very sick patients, with most patients had cavities in the chest X-ray, all previously treated with second-line drugs, a high hepatitis C co-infection rate, and half of the patients were XDR, and 1/3 were pre-XDR with resistance to quinolone. So it's quite a cohort of very, very sick patients. Regarding the previous drug use, almost all the patients received previously fluoroquinolone and injectables, and a little more than 1/3 of the patients received clofazimine in the previous treatment. And at the start of bedaquiline, clofazimine was prescribed for 80% of the patients. All patients received linezolid, and 3/4 of the patients received also imipenem. So here are the treatment outcomes. As you can see, the success rate was 58.5% in this cohort. We observed 10 deaths, 6 failure, and 18 loss to follow-up, which is about 22%. So quite a high loss to follow-up rate, but also a quite high success rate. Regarding the deaths, the median time to death was 8.8 months, and most of the deaths were due to advanced TB disease. For the loss to follow-up, what we observed is that 3/4 of the patients who were lost to follow-up were actually lost to follow-up after 9 months of treatment. Regarding the different factors that could be associated with the treatment outcomes, we didn't really observe any difference in the success rates according to the BMI at treatment start, according to the diabetes status, according to the DST, so similar success rate among XDR and pre-XDR, and according to previous exposure to clofazimine. However, hepatitis C co-infection remained associated with an increased risk of unfavorable outcome in this cohort after adjustment of all the other confounders. So in conclusion, this study shows very good results in very difficult to treat patients with a success rate of about 60%. So the WHO Global Report in 2016 showed a success rate among XDR-TB of only 28%. As I said, most of the deaths were due to advanced TB disease, and we observe also a high loss to follow-up rate mainly after 9 months, so MDR-TB treatment is still too long. However, the compassionate use program had very, very good advantages, such as, of course, it gave early access to bedaquiline, but also access to repurposed drugs, such as linezolid and imipenem. It has improved TB care and the clinician skills, and also the reporting and the management of the adverse event, the serious adverse event. And the limitations of the compassionate use were that the bedaquiline was prescribed only for 24 weeks, only for pulmonary MDR-TB cases, and we observed some severe TB cases like HIV co-infected patients who refused treatment. So I want to thank all the amazing staff in the field for this study, all my colleagues in Paris and Epicentre, and thank you very much for your attention.
So this looks challenging. Huh? We come out with the first presentation, we see that there's a proportion of success treated about 60%, but then you have 20% loss to follow-up, and then reversion to positive again is substantial. So now we have time for one question. Do you have any question from the audience? Yes, please.
Thank you for an excellent talk. I was wondering about how you read the chest x-rays to determine cavitation, because especially small cavities are often very difficult to see on a plain film x-ray, and I'm just wondering, did you have a radiologist or did you train the medical officers to do it?
I think I will let Cathy answer this question. I think she's more able to answer this.
In both Armenia and Georgia, radiologists read the x-rays.
Okay, we'll take one more question, then we move on.
Yeah, well, actually my question is maybe more on Katie's data, but it's the same cohort. I heard there's 20% reversion, and so my question is, what are those reversions? Is this amplification of resistance? And if yes, does this mean that this program creates, amplification of resistance in 20% of cases?
Thanks very much. Unfortunately, 6 other reverted patients died. One was actually cured. One was lost to follow-up, and 6 were failures, 2 died, 1 was lost to follow-up, and 1 was cured. We did send, for the failure cases, we sent cultures to Antwerp ITM. We were mainly trying to look for solutions to treat these patients further. So we did bedaquiline, clofazimine, linezolid, DST. We only found 1 patient resistant to bedaquiline. But certainly, when you're treating patients without enough effective drugs, and you have to stop one of the effective drugs, this is, of course, a very bad thing to do. And so I think it's really important for national TB programs to take the initiative like Belarus and use the good practice to keep enough effective drugs and not stop bedaquiline when they should continue.
Okay, thank you, Dr. Matthew.
Our next speaker is Dr. Minit in Kazakhstan.
Hi everyone, it's a great honor and very exciting to be here and talk about these new 2B drugs. They're certainly proving to be very effective tools in treating patients with high resistance and also treating patients that have any kind of risk factor for poor outcomes. I'm going to talk to you about the experience of concomitant use of bedaquiline and delamitid in the country of Kazakhstan. I have a number of colleagues with me here that can also add to this discussion. I'm presenting, I think, because my English is a little bit better than theirs, but they have more knowledge on the program, so we'll include them on any questions. Declaring this conflict of interest that I am part of a Unitaid NTB grant that is looking at how to use new TB drugs and also how to better use the repurposed antibiotics of linezolid and clofazimine. And we also, our programs do receive bedaquiline free from the USAID donation program. Bedaquiline and delamitid, as everyone I think in this room knows, are two recently approved drugs by both stringent regulatory authorities throughout the world and also by the WHO for drug-resistant TB. Both drugs prolong the QT interval, so there's been a lot of concern about possibly using them together. There's no contraindication in the drug labeling to use the drugs together, and it's technically not off-label use, but often people have some hesitancy, and because of this QT interval prolongation that they both have. And I'm going to present just on some preliminary results of 22 patients that received bedaquiline and delamitid together between the dates of April 2015 and September 2016. They were started on the drug. Those are the dates where they were started to be enrolled. And I'll also talk about the indications, why they got them, the duration, how long, adverse events, and 6-month conversion rates. This cohort is part of a bigger cohort. It's called the NTB Observational Study. This study takes place across 17 countries. You can see Kazakhstan has a lot of the patients in the cohort. So far, we've enrolled almost 1,400 patients in the cohort, and 136 of them are on both bedaquiline. Are on both bedaquiline and delamitid. So we're getting about 10% of their patients on both drugs. So we're getting some experience with this. I also do want to mention that the WHO just came out with this document. It's downloadable on the internet. It's called the WHO Best Practice Statement on Off-Label Use of Bedaquiline and Delamitid. And they do acknowledge that there's not much evidence about using bedaquiline and delamitid together, but there may be patients that have extensive resistance or experience drug intolerance or serious adverse events that need to put both drugs together. I think we can all acknowledge, as the providers of care to these patients, that it certainly is not best practices to use 2 drugs or 3 drugs to treat MDR-TB. And so when you're in a dilemma of not having enough effective drugs, it's very logical that you would put these 2 drugs together. And the WHO fully acknowledges this, that many patients may need both drugs together. Here's the cohort, just 22 patients that we have enough data on that we can comment on SAEs and conversion rate. Their average age was 32. They were about a little bit less than half male. 41% had a BMI of less than 18.5. At baseline, none of them had an elevated QT interval, and many of them were treated in the past, most of them, and not all of them were culture positive at baseline, because sometimes the bedaquiline and delamitid was, just like the other cohorts, were that were presented was added after they started some other drugs, but we recognized that we definitely needed to add more drugs to strengthen the regimen. So not all of them were culture positive at the start, but they all had some evidence of MDR, in most cases XDR, prior to starting the regimen that the bedaquiline and delamanid was added to. Here's a few more. This is the indications of why we decided these patients. If you can see that all of them, we added bedaquiline and delamanid because we thought they had a weak regimen without this combination use. And I do think that trumps, I would rather from what I know of the drugs, take the risk of using them together than take the risk of having too few drugs in my regimen if I was infected with MDR-TB. So this makes sense. A lot of them, we had evidence that they were actually the old grouping of the drugs, group 4 drugs, ethionamide, cycloserine, and PAS. We had evidence that they've used these before and they weren't effective then, or we had DST that showed them likely to be ineffective. So 18 of those patients, we thought that none of the group 4 drugs were effective in these patients. So these were highly, highly resistant patients. And one patient, we started on both bedaquiline and delamanid just because of their contacts resistant pattern. This is some more baseline characteristics. Sorry, this is a little out of order from the indications. It's supposed to go after the other ones. But you can see that a few of them had hepatitis C, 27%. Actually, this has kind of been a surprise as we've been testing everyone for hepatitis C with MDR and finding in this area that there's a lot of co-infection. And 9% had diabetes, and many of them had high drug resistance. Not all of them had XDR. On average in their regimen was 6 drugs. Second most commonly was 5 drugs. Sometimes we would add a drug even though we weren't sure if it was effective, so that's why they had 6. They likely didn't have, most of these patients didn't have, without the combination, wouldn't have 4 drugs that were thought to be highly effective, highly likely to be effective. We used a lot of linezolid with these patients, almost 100%, a lot of clofazimine, a fair amount of imipenem, 60%. So other drugs are in the play here too. And this I'm going to spend a little bit of time on. Let's see. I have like 10 seconds left. So I'll cut to the chase here. But in red is the bedaquiline and delamanid used together. And you can see that in the beginning of the program, this is sequentially at the bottom, we had bedaquiline, but we didn't have delamanid. So in the beginning of the program, a lot of people, once the delamanid arrived, we started adding it to it. So red is bedaquiline and delamanid, blue is just bedaquiline, and then the green is just delamanid. And you can see where where 24, so these are individual patients, and you can hopefully have access to this presentation and take a look at this more, and you can see how we use the bedaquiline and the delamanid. These are the side effects. There was only one serious adverse event, and that was QT prolongation, and it was a grade 3 prolongation. That actually occurred when the patient was just on bedaquiline at 2 weeks. The patient was hospitalized, and it went away, and we reintroduced the bedaquiline, and then the delamanid was added 4 months later, and the patient never had an episode of QT prolongation. So it was probably just a transient finding. Maybe his electrolytes were a little bit low or something that resulted in that. And this is the conversion date, and I'm almost done. Conversion data. So out of the 22 patients, we had 15 that had baseline, were culture positive. And so we're talking about conversion only in people that were culture positive at the start. 12 of them converted. And so this is, this compares to about a 20 to 25% conversion rate in XDR patients before we were using these drugs. And it's not just the new drugs, it's linezolid and clofazimine too in this combination for XDR. So this is extremely encouraging, and we've had this result in things. I'll just sum this up by saying these are very promising results. There's a lot of unanswered questions, and I think, you know, there's still questions about certain combinations of drugs and if those are more likely to lead to QT prolongation. I think we still have to monitor patients on both drugs, bedaquiline and delamanid, with ECGs. But there's a lot of questions that should we be using this concomitant use the whole time? Should we be using concomitant use of both the drugs, you know, more than 6 months? And would all patients with XDR benefit from this backbone of bedaquiline, delamanid, linezolid, and clofazimine? And I'll leave you with those unanswered questions, and we can further discuss them.
Thank you, Michael. We have time for
minutes.
2 questions, maybe. Any questions to the mic, please?
Thank you for excellent presentation. At the slide, you showed baseline characteristics of the patients. Patients monitored QT interval, only 16 patients monitored QT interval before inclusions.
Oh, I'm sorry.
And 22, but number of patients was 22. But only in 16 before inclusion, you monitored QT interval.
Only 16 patients were included in what slide?
That's with patient at
Conversion.
inclusion.
Yeah. Yeah.
Do you understand?
Can I go to the presentation?
No.
This one?
Earlier. The first slide. Patient characteristic before inclusion. This one, you see, you have only 16 patients with QT interval measured before inclusion. Why you didn't measure the QT interval in all 22 patients?
Oh, sorry. So patients that, oh yeah, I see.
It is very important before inclusion to measure QT interval because, you know, 2 drugs very important to prolong QT interval.
Yeah,
And before inclusion, you
Michael,
do
I don't know if
it's
Katya-
the QT over 450,
Yeah, I don't
more
know.
than
but-
450 in 16, no?
Yeah, but I don't know why it says 0, then n equals 16. If it said 16 in there.
16
Oh, the N
only
is
with-
16, yeah.
Yeah.
16 only QT
Katya,
interval
do
measured
you know
before
why
inclusion.
it's saying, what is this n equals 16? Should it be 16 here? All the patients had, I guarantee you all the patients had their QTCF measured prior to the start of therapy.
But
And
what
I
is
think this
16?
was supposed to report on how many at baseline had greater than 450 milliseconds at baseline. And I think the answer is 16, but okay, Katya's not. I'm sorry, I'm not. I think there's some error on here, but it was supposed to indicate at baseline how many patients had greater than 450 milliseconds at baseline, and I apologize for that error. I'll see if I can clarify it in the.
Okay, so I think that we'll leave it at this.
Yeah.
Thank you very much. And
Can I request Dr. Lavanya Joseph, if you are here, can you identify yourself? No, okay. Then we have 3 to go because Dr. Lavanya is not here. Okay, the next presentation again will be Dr. Matthew, correct? Okay, now you back to your another presentation, right? Bedaquiline and linezolid-based regimen for quinone-resistant MDR-TB. Okay, please.
Okay, thanks for listening me again. So I represent this study jointly conducted by MSF and Epicentre on the bedaquiline linezolid-based regimen for fluoroquinolone-resistant MDR-TB. How much better is it? I will manage this time or not? Okay, good. Okay. Sounds like a joke. Yeah, I saw. Already 3 minutes. Yeah, but... See, now it's dark. And now it's not working.
So we have technical problem here.
Maybe I upload just the title. Will be long presentation, huh? Okay, so let me do the background. So, okay, no. No, I don't know.
No, it's not working. There's a 0.2 there. No.
Okay, so as you all know, treatment of fluoroquinolone-resistant MDR-TB patient is very challenging. Ineffective treatment can lead to lack of conversion, reversion after initial conversion, or acquisition of further drug resistance during treatment. However, treatment regimens including bedaquiline and repurposed drugs have shown higher success rates. And today, only a limited number of patients globally have access to these drugs. So the objective of this study was to assess and compare the MDR-TB treatment outcomes of a cohort of patients receiving WHO-recommended MDR-TB treatment without the new drugs with a compassionate use cohort receiving WHO-recommended MDR-TB treatment with the addition of bedaquiline through compassionate use and repurposed drugs, linezolid and imipenem. So the countries where the study took place is Armenia, with a high rate of MDR-TB. So in 2016, we found 11% of MDR among new TB cases and 47% MDR among previously TB cases. And MSF is supporting MDR-TB treatment in Armenia since 2005. So I won't spend a lot of time on the compassionate use because it was quite presented before. So this is a retrospective analysis. The compassionate use cohort is the patient who received the WHO MDR-TB treatment with the compassionate use of bedaquiline and the repurposed drugs, and the non-compassionate use cohort, non-CU cohort, is the patient who received the WHO treatment without the compassionate use of bedaquiline. So this cohort is built of patients who started treatment before the 1st April of 2015, and among patients resistant to quinolone, so pre-XDR, resistance to fluoroquinolone, and XDR patients. So I will describe the baseline characteristics of both cohorts, the success rates of both cohorts, and compare the success rates through multivariate modeling to adjust for potential confounders. And also a small sensitivity analysis just to exclude the loss to follow-up patient to see if we obtain the same trend. So this is the baseline characteristics of both cohorts. So the non-compassionate use cohort was 111 patients, and the compassionate use cohort was 49 patients. So what is very interesting here is that we can see that the patients were similar, very sick patients. Almost half of them were XDR. Similar characteristics, quite high number of male, age less than 35, about 30% of them in both cohorts. A median BMI similar. The difference we observed is that in the compassionate use cohort, all patients were previously treated. And again, in the compassionate use cohort, 30% of the patients received clofazimine before, compared to only a few patients in the non-compassionate use cohort. So what we should keep in mind here is that both cohorts are very similar. So these are the treatment outcomes. So we'll go straight to the success rate. So in the non-compassionate use cohort, the success rate was 18%. And in the compassionate use cohort, the success rate was 61.2%. So I put the p-value, but I guess it's clear that the difference is very impressive. And now if we go a bit in details in the outcomes, what we can observe is that the difference actually is among the failures. If we look at the non-compassionate use cohort, we had 45% of treatment failure. And in the compassionate use cohort, we had only 10% of treatment failure. And in both cohorts, the death rate and the loss to follow-up rate was very similar. So the actual difference of the success rate is really that we had a big decrease in the failure rates in the compassionate use cohort. And this is confirmed that if we exclude the loss to follow-up from the analysis, just to better assess the treatment efficacy, we observe the same trend, even higher, and a very high difference on success rates in advantage of the compassionate use cohort. So just to confirm these results, to adjust this patient who received bedaquiline to make a multivariate model to take into account all the different characteristics of the patient, we find a quite strong effect, strong positive effect of receiving bedaquiline on treatment success with a high adjusted hazard odds ratio, despite the wide confidence interval due to the relatively small number of patients, but still the effect is here, is very strong, and it's even higher when we exclude the loss to follow-up from the analysis. And this is adjusted for all the baseline characteristics that I have previously shown, and also for adherence rates, which is important. So in conclusion, the regimens containing bedaquiline and repurposed drug are vastly improve the treatment success rates compared to previously available conventional treatments for fluoroquinolone MDR-TB patients in Armenia. But despite this evidence, amongst the notified MDR-TB cases worldwide, today less than 5% of fluoroquinolone MDR-TB patients have been treated with bedaquiline. And an important scale-up of access to bedaquiline and repurposed drugs should be a priority now. So again, I will thank all my colleagues in the field and my colleagues in Paris and in Epicentre. Thank you very much for your attention.
Thank you. We are very happy to see that by the use of bedaquiline, the success rate improved. But perhaps we all agree that 60% is still not good enough. We still need to find a way to get it even better, right?
Yeah,
okay,
even better for sure, but it's a very sick patient.
We have time for question. Any comment, question from the audience? Yes, please go to the microphone.
Very nice talk, Yao from FHS China. Just to clarify, for the non-compassionate group, are they also have access to linezolid?
No. Linezolid was really a repurposed drug, so they were not receiving linezolid in the non-compassionate use cohort.
Okay, if there are no more questions, thank you, Dr. Matthew. Oh,
Thanks for the presentation. What's the duration of treatment for two groups? Treatment duration.
It was the same treatment. Just we had the bedaquiline and the compassionate use and the repurposed drug in the compassionate use cohort, but it was the same treatment, the treatment recommended by the WHO. Sorry? The 20 to 24 months in both groups.
Is there any more question? If no, thank you, Dr. Matthew.
South Africa, Khayelitsha, who's going to talk us about the observational cohort study with the laminate. You have the floor.
Okay. Good Good afternoon, everybody, and thanks for allowing me the opportunity to speak this afternoon. As mentioned, my name is Erica Moore, and I'll be presenting on the use of Delamanid for the treatment of rifampicin-resistant tuberculosis. And I'll be presenting results on an observational cohort study which was conducted in Khayelitsha, South Africa. Okay, and first I'd like to make known my declaration of interest. Okay, so as many people have already mentioned, Delamanid is efficacious in the treatment of rifampicin-resistant tuberculosis, or RIF-resistant TB, and it was recommended by the World Health Organization in 2014. This recommendation was on the basis of randomized controlled trials. One of these RCTs found that Delamanid, when given to patients for 2 months, had faster and higher rates of culture conversion when compared to patients who received Delamanid for less than 2 months. Delamanid is relatively safe and has no drug-drug interactions with antiretroviral therapy and can be given in conjunction with efavirenz, and therefore it's potentially useful in HIV-infected patients. However, Delamanid does have QTc prolongation, but this can be monitored using electrocardiograms. Experience with Delamanid outside of clinical trials is, however, limited, particularly among patients with HIV and co-infection. So Delamanid is one of the first new drugs that we have available for the treatment of RIF-resistant TB within 40 years. However, access to Delamanid has been relatively slow. As you can see, this is a graph which shows the cumulative number of persons that have been started on Delamanid from July 2015 to July 2017. And to date, there's only about 700 patients that have received Delamanid. This represents about 5% of the patients that are eligible to receive this drug globally. And so, additionally, the factors that have limited access to Delamanid are limited narrow indications for Delamanid, as well as lack of registration of Delamanid in the countries that face high burdens of RIF-resistant TB. However, MSF has been able to procure Delamanid through the GDF, and in Khayelitsha, South Africa, we've been accessing Delamanid for a subset of our patients from November 2015. So we conducted an observational cohort study of patients who had Delamanid included in their second-line TB treatment regimen between the 1st of November 2015 through the 31st of August 2017. We reported on interim treatment outcomes, median QTcF change over time, as well as sputum culture conversion by 2 and 6 months. So Khayelitsha is a peri-urban township located on the outskirts of Cape Town, South Africa. MSF has been working in Khayelitsha since the late 1990s, and in 2008, MSF implemented a decentralized model of care for the management of drug-resistant TB treatment in South Africa, in Khayelitsha. Post-handover of the decentralized model of care in 2011, MSF has continued to pilot interventions to work on improving the management and treatment of drug-resistant tuberculosis. So MSF provides support to the 10 existing primary healthcare facilities that exist within Khayelitsha, and the case notification rate of RIF-resistant TB in Khayelitsha is 55 per 1,000 population, and there's about 200 cases that are diagnosed annually, so it's a relatively high burden setting. Of those patients that are diagnosed, 90% are initiated on second-line treatment, and the median time to treatment initiation is 7 days. As we also have a high burden of HIV within Khayelitsha, so 70% of our patients are co-infected. So patients eligible to receive Delamanid through MSF were patients in whom second-line drug treatment had failed, patients with intolerance to the second-line treatment regimen. So for example, patients susceptible to fluoroquinolones with intolerance potentially to the injectable, and patients with limited therapeutic options, so patients with fluoroquinolone resistance. For this study, we defined culture conversion as 2 consecutive negative cultures at least 30 days apart, and the QT interval was corrected using the Frederica formula to eliminate overestimation of the QT readings. So to date, we've enrolled 103 patients within the cohort, and the median age of those at Delamanid initiation was 34 years. Over 50% of the cohort were males. as previously indicated, we had high rates of HIV co-infection. We have high rates of HIV co-infection in our population. So 77% of the patients that have received Delamanid were HIV infected, and the median CD4 count was 141 at Delamanid initiation. So you can see that the majority of these patients had advanced HIV disease. Regardless of this fact, 94% were on antiretroviral therapy at Delamanid initiation. Nearly 40% of the patients had MDR, and approximately another 40% of patients included in the cohort had second-line resistance. So we can see that this is a relatively sick cohort of patients. Over 50% of the patients included in the cohort had some form of previous TB treatment history, whether it be first or second-line TB treatment history. And the main indication for Delamanid was intolerance, followed by limited therapeutic options, and finally, treatment failure. The median time to Delamanid initiation in this cohort was 1.5 months. So it's important to note that the majority of the patients receiving Delamanid had Delamanid added to an existing regimen that had 3 or 4 effective drugs. Okay, so what's happening to the patients in the cohort? Of the 103 patients enrolled in the cohort, you can see that 36 are alive and still on treatment with Delamanid, compared to the remaining that are no longer on treatment with Delamanid. Of those patients no longer on treatment with Delamanid, 7 patients had Delamanid withdrawn. This was due to interruption of Delamanid, serious adverse events. Patient was switched from Delamanid to bedaquiline, or the patient had travel and therefore Delamanid was withdrawn. In the remaining patients, sorry, I'm having trouble reading these figures. You can see that the majority of patients had completed treatment with Delamanid. 14% of patients, sorry, I can't see this. 14% of patients had died. You can see the proportion of patients that were lost to follow-up and the proportion of patients that were transferred out. Of those patients that had completed Delamanid, the majority of them were still on RIF-resistant TB treatment. Some patients had experienced an outcome of treatment success. Some were lost to follow-up, some experienced mortality, some had treatment failure, and some were transferred out. Okay, so here's the interim outcomes for the cohort stratified by HIV status. And in the right column, you can see the median time in months from Delamanid initiation to an outcome. Okay, so I'm not going to go through the whole table with you, but important to note is that the majority of patients in the cohort were still on RIF-resistant TB treatment and culture negative at the time of this analysis. So 52% of those HIV positive and 67% of those HIV negative. Here we can see the QTCF values over time from week 0 to week 24, and we see that the median value, or the median values, ranged between 400 and 450 milliseconds, and there were very few instances in which there was a QTCF greater than 500. So overall, there were 4 instances in this cohort where there was a QTCF value greater than 500, and this occurred in 2 patients. Okay, for our analysis of culture conversion, we looked at patients who started treatment before the 1st of January 2017. 45% of those patients were already culture positive at Delamanid initiation, so this analysis included 31 patients. Of those patients, 52% were culture converted by month 2, and 81% were culture converted by month 6. So in total, we had 25 patients culture converted out of the 31 included in the analysis. Of the 6 patients not converted by month 6, 1 was lost to follow-up. So in conclusion, we found that early treatment outcomes using Delamanid in a programmatic primary healthcare setting with a high HIV prevalence rate were extremely promising. Our experience shows that Delamanid can be offered as a treatment option for RIF-resistant TB patients in a decentralized setting, and we believe that access to Delamanid should urgently be expanded. In the background, you can see a photo of a young girl. She was an adolescent patient, a young girl that we put on Delamanid under the age of 18, and she had XDR-TB, and she's actually now successfully treated, and she was the first adolescent patient that we managed to put on Delamanid. I'd like to acknowledge our following partners. And then also I'd like to ask governments to step up for TB and assist in the rollout of new drugs for the treatment of RIF-resistant TB. Thank you very much.
We have time for a couple of questions.
Thank you very much. My question is about the loss to follow-up cases. You stressed on the option to have Delamanid for these cases. Only 700 had access to this drug, but you did not mention about loss to follow-ups and the problems related with the treatment. As far as we see in your series, that the other problems are far more than the lack of Delamanid, you know, because you should have a good program. Loss to follow-ups should be very, very small. The side effects should be managed very well, and the follow-up of the patients should be very well. If they are absent, adding Delamanid, adding bedaquiline, adding new drugs, that will not solve the problem. The problem increases. So we should have a good program, zero loss to follow-ups, a good follow-up of all side effects and other problems, then using new drugs would be more logical. Thank you.
Okay, so in terms of our loss to follow-up rates, I think generally we want to provide our patients with the best treatment that there is available. However, we would still like to advocate for shorter regimens, as we recognize the challenge is that we still have a 24-month treatment regimen, and despite the fact that we have new drugs available, that doesn't mean that now patients aren't still struggling with a long treatment duration.
Thank you very much for your talk. I apologize if I missed this. I think currently one of the contraindications to use of Delamanid is still very low serum albumin levels. And I noticed that in your HIV-infected cohort, you were dealing with very sick and immunosuppressed patients. So I just wondered to what extent hypoalbuminemia was assessed and whether that was an obstacle to Delamanid therapy for some patients.
Sorry, I had trouble hearing part of what you said.
I think, what do you want me to do? I think at present, one of the contraindications to Delamanid therapy is hypoalbuminemia, an albumin level of less than 28, for instance. And as you were treating a very sick cohort of HIV-infected patients with low CD4 counts, I just wondered how many patients you were prevented from using Delamanid in because of low albumin.
So our doctor is here, and she can actually comment on that.
Thank you for your interesting...
Sorry, I'm just going to answer. Yeah, we did have quite a bit of, well, not quite, but we did have some hypoalbuminemia, but we tended to initiate Delamanid slightly lower than the cutoff at 28, but we made sure that it was on like an increasing trend. So we were giving them high-protein diets, and we were monitoring it very closely, as well as adverse events. Sorry, could you not hear me there? Sorry, so we did have some hypoalbuminemia, but we were giving supplements and we were monitoring very closely. We didn't give below a level of 18, but we were giving below a level of 28.
So, thank you for your excellent presentation. My question is, as far as I understand, maximal duration of Delamanid treatment was 6 months. Is it correct?
Some patients are receiving over 24 weeks of Delamanid, over 6 months.
Over 6 months. How long it was?
Sorry, how many patients received over 6 months of Delamanid? I believe it's about 30, 38 patients, somewhere around there, in total in the cohort.
Just to share our experience in Belarus, if we see we didn't achieve culture conversion at 4 months, we continue with Delamanid. We don't stop it. Because Delamanid, it is the most effective drugs in this treatment regimen. Thank you.
Maximum duration would be 1 year, so...
Thank you for your presentation. How many patients use the linezolid as a companion drugs?
I can't remember off the top of my head, but I can let you know after this.
So probably about half of that cohort were on linezolid because we tended to give linezolid to anybody who had treatment failure or fluoroquinolone-resistant TB. So generally the ones with fluoroquinolone-susceptible TB, we weren't giving linezolid as well. Maybe a couple if there was an adverse event to another second-line drug.
Thank you very much, Dr. Moore and colleague. I think we're going to have to close here.
From Ethiopia. Here we present the drug-related tuberculosis burden among contexts of drug-related TB patients result from routine program implementation in 3 regions of Ethiopia.
Thank you. Good afternoon. I will move you from treatment regimen and treatment types to one of the TB case finding strategies, which is contact screening. I will be presenting on contact screening yield among program implementation in Ethiopia in 3 regions of the country. As some of you may know, Ethiopia is found in East Africa. It has a population of close to 100 million and is among the high burden TB, MDR TB, and TB HIV countries. The current incidence rate for the country is 192. And the co-infection rate is 8%, and the drug-resistant TB among new is 2.7, and among retreatment is 40% using the latest study. The MDR TB success rate for the 2030 cohort is about 68%. Our objective was to conduct a systematic screening of contacts of drug-resistant TB in 3 regions of the country. These 3 regions of the country constitute more than 60% of the country. And we are presenting the yield of this intervention. The methods we used were conducting contact screening for contacts by visiting them to come to health facility and by making home visit for those who are not able to come to health facilities. Home visit will be conducted. So we used 2 methods of contact screening. The project, that means USAID Challenge TB, supported by training staffs who are working on treatment initiating centers and preparation and distribution of guidelines and algorithms and provision of recording and reporting format. We did by supporting the national TB program in fulfilling these guidelines, recording and reporting formats, and by conducting regular supportive supervision, mentorship to the health workers working on drug-resistant TB initiating centers. This is a study area, and you can see the treatment initiated centers spread across the country. They are found in different corners of the country, and our analysis refers to the 34 TICs which are found in these regions, 34 treatment initiating centers. And the information covers a 1-year data of 2016. The method of screening we used looked like this, and the contact screening was conducted per the national guideline. National TB program, there is a national endorsed guideline which we follow to screen each patient, and family members are invited to health facility, and those who are not able to come to health facility are screened by home visits. And a trained health workers does this activity, and the algorithms looks like this. The contacts are identified here and screened for the signs and symptoms of TB. Those with TB systems will undergo gene expert test as a primary test, and those without TB symptoms will be
served with quarterly follow-up of screening similarly. This is a health worker counseling a TB patient to bring his contacts. First, a recording is conducted. So this is a treatment counseling session and convincing the patient to bring the contacts, and other educational materials are given during this kind of consultations. Coming to the result, as you can see, we have been able to screen 457 contacts, which is 95% of the contacts registered, and we have found TB cases with a case notification of 1,330. The cumulative case notification for yield among contacts is 1,330, which is very larger than the yield we expect from the drug sensitive per the global estimate. So the cumulative yield has been 1.3% of contacts were found to have drug-resistant TB cases, which translate to more than 3,000 cases per 100,000 contacts for those. This yields, when we see we conduct similar kind of screening for contacts of drug-sensitive TB patients, and the yield for drug-sensitive TB patient is lower. We compared the same duration for drug-sensitive contacts is lower, about half of the yield which we found. There is a regional variation. Oromia region is the one with the highest yield, and you can see the regional variation. As a conclusion, the yield among drug-resistant TB contacts is more than 7 times compared to the TB notification estimate in the general population for drug-sensitive. And when we compare the contacts yield for drug-sensitive and drug-resistance, the drug-resistant is almost twice higher yield than the drug-sensitive contacts. So we are recommending continued strong screening for contacts of drug-resistant TB on regular basis. Thank you.
Thank you. Any question from the audience? No? So your presentation has been very clear, so there's no question. So now we still have 5 minutes. Do you have any general comeback or questions to any of the presentation? Today we have impressive results from Belarus that you have a high retention of the patients, but from other settings, we see that with the use of bedaquiline and denamide, it seems the challenges remain the loss to follow up. So new drugs are useful, but we still need to find a way to support our patient to continue the treatment, right? And then from Dr. Rich, we see that it's also possible to have a combined treatment of bedaquiline and denamide, and this contact examination remains important. It would lead us to early detection of drug-resistant tuberculosis. So is there any further comment or question from our audience, please? Please go to the mic. Yes.
I was just going to quickly follow up on the 16 patients. So all the data came from an electronic medical record that captures all aspects, and a lot of the ECGs, the early ECGs, weren't entered into that system. So we have to go back to the paper charts and get that data. So we only had baseline ECG information on 16 patients, and they were all their baseline ECG had QT intervals less than 450 milliseconds. So that's where the 16 is. So thank you for the question.
Thank you, Michael.
Hi, Paul Nunn from London, and chairman of the TB section. Thank you very much for a very interesting range of presentations, much of which, or many of them of which, focused on the Armenia-Georgia situation. And I'm just curious to know about the compassionate use program and the 6-month limit. I'm assuming that you were absolutely fixed to that 6-month limit by the program or by the manufacturers. MSF is normally the self-confessed bad boy of public health. So I'm kind of wondering why MSF put up with that. And the follow-up question is, has that compassionate use program now extended the availability of bedaquiline beyond 6 months?
Yeah, thanks. 2 great questions. So we pleaded, we wrote, we did everything possible to get the bedaquiline for more than 6 months. We had a compassionate use medical committee with experts, international experts. They wrote a letter, we wrote letters, and we pleaded with the drug company to have more than 6 months of bedaquiline. And they said no. They said, under the compassionate use program, we cannot give you more than 6 months. So as soon as compassionate use finished, in fact, MSF, Armenia and Georgia were the first people to buy bedaquiline. They bought it before even the donation. And as soon as we got that bedaquiline, we started using more than 6 months. So it was really restrictive for us for compassionate use. But on the other hand, compassionate use gave us bedaquiline 2 years before we could get it through from buying it. We couldn't buy it for 2 years. And it helped us, the compassionate use program, the mechanism that was set up in Armenia and Georgia, it meant as soon as Delamanid was available through compassionate use, they immediately were able to use Delamanid also. And they're going to use that when other drugs come out. And there was a study done recently that showed that countries that use compassionate use have earlier rollout of new drugs once they become available on the market. And I would really encourage countries, even if you don't have that mechanism, create a mechanism. It was not even finally very complicated, but create a mechanism so that you can get early use, the doctors get used to it, and then they're just so happy to use these drugs once they're on the market.
No, just as a follow-up, I mean, I'm intrigued by the fact that it seems now that organizations like MSF, Epicentre, and so on are actually doing the work of the drug companies for them. I mean, Janssen essentially provided you with an unfinished product, which was likened by a friend of mine yesterday to like Nike developing a pair of trainers, but only delivering the left foot rather than the right foot. And they really should have gone beyond 6 months, as should Otsuka, of course.
Well, certainly we appreciate the conditional registration after the only phase 2 trials because patients have survived because of that. But phase 3 trials are expected, and Otsuka, I think, are presenting their results this afternoon. But Janssen, we are waiting for phase 3 trials, yeah.
I have one quick question for Alina from Belarus. It seems that your MDR-TB patients before the introduction of new TB drugs and non-XDR are not having very good results. And it seems like everyone in Belarus could benefit from a new TB drug. Have you thought about using a new TB drug in all MDR-TB?
Thank you for this question. We have possibility to get only for 60% of our patients who needs new drugs. It is a great pity, but we did everything to increase the proportion of patients who can be put on new drugs containing regimen. And it is difficult to do it because we did everything was possible. For example, we use not only Global Fund for that, we have MSF collaboration, which is increased number of patients which we can put on new drugs. And now we are eligible, Belarus is eligible for bedaquiline as a country with highest proportion of MDR TB in the world. But we cannot use bedaquiline like monotherapy. We have to have at least clofazimine and other containing regimen. It is the reason why we can not use is, as far as I know, in neighboring countries. You know, they use bedaquiline, for example, without clofazimine and linezolid. All our patients who on new drugs, bedaquiline or delamanid or bedaquiline plus delamanid, they are all on linezolid, clofazimine, and most of them on imipenem with amoxiclav, and other seems to be effective drugs. It is why. I think I answer your question. Thank you.
I hope the acoustic of the room can cope with my Scottish accent for a second time. Just a quick comment and question about this issue of bedaquiline beyond 6 months, because I agree with there is a real paradox, I think, by saying that we have to give bedaquiline to patients who have so few other options and then not being able to continue it for the entire duration of therapy. And I certainly have personal experience of extending bedaquiline out to 18 months for a patient in which we could barely put a regimen together otherwise. But with regards to the data from Armenia and Georgia, which suggest culture reversion after stopping bedaquiline at 6 months, it just makes me think of arms of the STREAM, Practical, and NTB trials that are trying to construct short MDR-TB treatment regimens, some of which are based in bedaquiline and some of which stop at 6 months. Now, should we be concerned about that type of regimen if you're reporting culture reversion with bedaquiline stopped at 6 months? Or are we only seeing culture reversion in patients who have such extensive drug regimen that they're extensive drug resistance that their regimens were wholly inadequate otherwise? I just wondered if you had any thoughts.
So I think it's a very good question. I think this cohort of compassionate use patients is not representative of all MDR-TB patients. Particularly, they had a lot, second-line drug use, all of them, but clofazimine particularly. So I think that's important, and I think the idea of introducing an effective regimen as soon as possible to have as many effective drugs is the key to that. But yeah, I think there will probably eventually be some other criteria, such as extensiveness of the disease. I mean, some of the x-rays of these patients, you can barely see any lung tissue, you know. So I think maybe these types of things will be criteria for extension beyond 6 or 9 months in these kinds of patients. Yeah.
I just wanted to check if I saw Crispin from Janssen here in the room a bit earlier. I don't know if somebody from Janssen is in the room to respond to the 6 months cutoff. There you are, Crispin.
So guilty as charged. I oversaw the bedaquiline compassionate use program, and I was the person that would send a response to say we cannot give you more than 6 months of bedaquiline. So remember, at that time, we had just discovered a mortality imbalance between the bedaquiline arm and the placebo arm of the pivotal C208 study. And we were under great pressure from the regulators, from our management, and from other areas to be able to sort that out. And before you could try to push more bedaquiline to patients as sick as these patients had been, we wanted to have a level of confidence that what we were doing was not harming patients more than it was helping them. So that was part of the philosophy that went into the refusal to give more bedaquiline beyond what was previously planned. I was heartbroken because I knew that some of these patients, when I looked at the drug susceptibility test profiles, essentially were on 1 or 2 drugs. And to me, as a TB doctor, I would never want to do that. But circumstances were such that from a regulatory standpoint, there was some pressure to be able to not do things that would jeopardize the ability of us to have bedaquiline today. Because should something happen in those instances and someone says, why did you do that? The default is to say, no, you cannot make bedaquiline available to anyone going forward. So those are the things that need to be balanced in this kind of context. So I hope I addressed that adequately.
Thank you for that clarification, Crispin. That was very helpful. I'm afraid we don't have any more time for questions, and thank you very much, colleagues, for sharing all your experiences, and continue the good work. Thank you.